Morning, everyone. Welcome to the infectious diseases component of the Friday morning academic meeting. Thank you all for joining. We are going to hear about an interesting case. Dr. Nkambule is going to present a case that we saw in the ward that was transferred to us from an outlying hospital with an interesting history. It's a fairly an unusual but classic presentation of this condition, and I think Salmonella is not always on our radar until the NICD says there's an outbreak. I think it's interesting just to recap. So please go ahead, Happy.
Okay. Morning, everyone. I hope all of you have eaten your breakfast, and I hope you did not lick the bowl. My name is Happy Nkambule. I'm one of the infectious disease registers. First, I would like to now present our case. It's Miss JM. Miss JM is a 42-year-old female mother of 3 from Tembisa. She's currently unemployed with sober habits. She has a background retroviral disease diagnosed in 2018, and she defaulted her TDF, FTC, and efavirenz-based regimen with no reason, no previous opportunistic infections, no recent CD4 counter viral load. She presented to Edenvale Hospital with a month history of a right femoral mass associated with fever, diarrhea, malaise, generalized body weakness, as well as discoloration of her feet, hands, and a swollen right leg. She had no other masses noted, no recent admissions, no prior surgical history, and not on any treatment currently. On examination, she looked chronically ill. Her blood pressure was within normal limits with a tachycardia and a low-grade fever. She had gangrene of the digits of the feet extending to the MTP, the right hand on the right and the 4th digit. She had right pedal edema extending to the thigh with an associated right femoral mass of 10 by 10 centimeter that was pulsatile with an audible bruit. There were no other masses and no radial delay or radiofemoral delay. Sorry, I just had a TIA there. No renal bruits were noted. The rest of the examination was unremarkable. I'm just going to show you some of the pictures and just be warned that they might be not pleasant to your eyes. So this is what her hands and feet looked like. You can see her left foot, her right hand, and the right foot, and that dry gangrene. These were the blood results from Edenvale Hospital, which demonstrated on the full blood count a severe microcytic anemia, and she had a grade 0 thrombocytopenia, which was on a downward trend. And on a UNE, she had renal dysfunction with a urea of 15.2 and a creatinine of 172, and the UNE looked Edisonian. She had a raised CRP, and she had hepatic dysfunction with raised transaminases and ductal enzyme. The CD4 count came back as 56 with a negative serum CRAG with a viral load of 2,050 copies per minute per moles. ANA, her ANCA was negative. Her TPHA was reactive, but with a non-reactive RPR. Hepatitis B and C serology was negative. We did imaging for her. Sorry. We did, blood cultures came back positive for Salmonella enterica subspecies enterica, which is my focus of this talk. And her imaging, she had an ultrasound which demonstrated a pseudoaneurysm that was initially thought to be iatrogenic, and subsequently had a CT angio. And this is the video of the CT angio, which demonstrated a large right pseudoaneurysm from the anterior aspect of the common femoral artery with a hematoma and air loculations, which is what actually led us to think this was a mycotic aneurysm. She had an associated right femoral filling defect, and the rest of the vasculatures was normal. And you can see, just wait a bit, and then you'll see on the right, which is this side, where you will see the huge aneurysm, which was there. Sorry, I missed it there. And histology of the biopsy that was done intra-op, it demonstrated a necrotic tissue with fibrin and suppurative inflammation, which was consistent with a septic aneurysm. And the Z-Nielsen stain was negative. She was then assessed as a 42-year-old female, RVG reactive, with immunological and clinical failure due to treatment interruption, now presenting with non-typhoidal Salmonella septicemia complicated by multi-organ dysfunction with acute kidney injury, delirium, liver dysfunction, likely septic cholangiopathy, disseminated intravascular coagulopathy, a right femoral mycotic aneurysm complicated by digital gangrene, right lower limb deep vein thrombosis, concern for infective endocarditis, and a transthoracic echo was requested, which did not demonstrate any vegetations. So now I'll be talking about salmonellosis, which refers to a symptomatic infection that is caused by an organism referred to as Salmonella. Salmonella was initially discovered in 1884 by Daniel Elmer Simon, who was a veterinarian pathologist who was helping, who assisted in the isolation of the first organism known as Salmonella chlorales in the GIT tract of pigs. It causes a spectrum of diseases in both humans and animals that can range from a simple self-limiting gastroenteritis to the more devastating enteric fever. The severity of the disease is always dependent on host factors, as well as the serotype of the Salmonella. It is one of the most common causes of foodborne outbreaks and acute diarrheal illnesses. This includes traveler's diarrhea. The epidemiology of salmonellosis, just to track back, salmonellosis or salmonella infections, they can be typhoid or typhoidal, which I'll unpack on a bit later. Typhoidal salmonella is endemic in developing countries or developing world, especially in African countries like Sub-Saharan Africa, Southeast Asia, and South America. In these areas, about 20 million people annually experience enteric fever, and up to 160,000 of these unfortunately would demise. Non-typhoidal salmonella, it occurs worldwide, but it does appear to be endemic in the developing world. This is because the developing world, not all cases are actually reported. So more of the developed world reports their cases than us developing world. So hence it might actually be endemic in the developing world. About 93 million of cases occur of non-typhoidal salmonella. Up to 155,000 of these individuals, unfortunately, will succumb to the illness. The incidence in many countries is actually currently on a rise. This is because of the rapid urbanization, which leads to overcrowding. The peak incidence occurs during rainy seasons, and it is considered disease of the poverty because in most areas with salmonella outbreaks, it's due to poor sanitation. It is one of the 4 causes of diarrheal diseases. Transmission of salmonella is different for both groups of organisms, non-typhoidal and typhoidal. Typhoidal one, because it's predominantly, is highly adapted to humans. So therefore its method of transmission is from human to human contact. So next time you shake someone's hand, always think that they might actually have salmonella. Non-typhoidal salmonella, on the other hand, it has a broad range of hosts and transmission occurs via many routes. One route is that due to exposure to animal food products, such as eggs, which they have been notorious in many outbreaks, especially with Salmonella enteriditis. Also poultry, ground meats, as well as dairy products, especially unpasteurized milk. Being vegetarian or vegan does not save you from salmonella because fresh produce can be contaminated with animal waste, and this is how you can actually acquire salmonella, in non-typhoidal salmonella. It can occur in domestic animals, including wild animals as well, such as reptiles. Salmonella, it's part of a genus of gram-negative bacilli of the family Enterobacterales, which was previously referred to as Enterobacteria Bacteriorhizia. It's a non-spore-forming organism, flagellated, that's intracellular and facultatively anaerobic bacilli, meaning that it's capable of both anaerobic and aerobic metabolism. It is characterized by 3 antigens, which are quite important in the classification of the organism. It's your OH and Vi antigen. Your O antigen is your somatic antigen, which is a carbohydrate component of your lipopolysaccharide, and it's important in the pathogenesis of the organism. Your H flagellar or your flagellar antigen is important for motility of the organism as well as binding of the organism to your epithelial of the enterocytes. Your Vi antigen is a capsular antigen, which is important as it provides virulence for the organism, and it's quite important for typhoidal salmonella. It is a ubiquitous organism with a broad range of hosts. Some of the organisms are adapted to only human hosts, like I've said earlier, especially with your Salmonella typhi. Using this antigen, Kaufman and White came with a system that classifies Salmonella into 2 big broad groups. You have Salmonella bangori and your Salmonella enterica. Salmonella enterica, it has all the serotypes that cause infections in humans and some in animals. It is further subclassified into 6 serotypes. You have Salmonella enterica, subspecies 1 enterica, which can further be subdivided into typhoidal salmonella and non-typhoidal salmonella on the basis of clinical presentation and as well as the presence of Vi antigen. Salmonella enterica subspecies 1 enterica, as I've said, can be divided into 2 broad groups, your typhoidal salmonella and your non-typhoidal salmonella. Typhoidal salmonella, which I'll just talk about it slightly, usually causes enteric fever, which can either be typhoid fever or paratyphoid fever. Non-typhoidal salmonella, on the other hand, can be quite confusing when it comes to naming of it. So here on the slide, I just demonstrated how they've actually on literature, when you read, they can actually be simplified. So the name that you see at the bottom is what you might see some articles be written as a Salmonella typhimarinum, but the full name of it, it's Salmonella enterica, subspecies enterica, serotype typhimarinum. Enteric fever is a severe systemic illness which is characterized by fever, abdominal pain that is caused by the disseminated infection with Salmonella typhi or Salmonella paratyphi A, B, and C. The clinical presentation of enteric fever is usually a sustained fever with hepatosplenomegaly, and occasionally they can have rose spots, which are demonstrated on your right-hand side. And the incubation period is 14 days, and the symptoms can persist up to 3 weeks. Diagnosis will be demonstration of the organism either on blood, bone marrow, or another sterile sites or intestinal secretions. And you can also biopsy the lesion and it will actually show you the organism. As if we haven't had enough of outbreaks. COVID we've had, now Salmonella this year in February, the NICD reported an outbreak of typhoid fever in the Western Cape and Northwest. So this is why it will be very important to always have typhoid fever or non-typhoidal salmonella as a differential diagnosis for any patient that presents with non-specific features. So now going back to non-typhoidal salmonella, the pathogenesis of non-typhoidal salmonella, it starts with the ingestion of the organisms, which of course will be obtained from contaminated food products or water. And you will require as little as 200 organisms for you to start experiencing symptoms of gastroenteritis. Once you've ingested this food, the first encounter or the first barrier of protection that we have is the gastric acidity, which protects us from colonization, but not in all cases, because 1, there's disorders that increase the pH of the stomach, and 2, there's certain organisms or certain strains of non-typhoidal salmonella that actually have adaptive response to this acidity. And once they adapt, they end up colonizing the lower GIT tract as well as the small intestines. and this is where the infection starts. Once they are colonized, they interact with the epithelium by traversing the mucosal barrier, and you have the fimbrium, which binds to the epithelium or the enterocytes, and that binding will lead to changes in the cellular cytoskeleton, and that changes will lead into ruffling of the membrane, and that ruffling of the membrane will reach out to the organism and enclose the organism into a vesicle. And then this is what leads to the first symptom of diarrhea. Once this is in a vesicle, it attracts or it stimulates your pro-inflammatory cytokines that recruits your neutrophils, especially in your non-typhoidal salmonella. So the neutrophils, which will lead to the diarrhea. And in typhoidal salmonella, there's recruitment of macrophages. This vesicle will then encounter your phagocytome inside, but it survives that, and it leads to, it becomes translocated into your basolateral membrane. And then once it's translocated to the basolateral membrane, then it encounters the macrophages, which then it leads to the dissemination of the disease, which can disseminate into the liver and the spleen. Dissemination into the liver is actually quite important because it would lead into, oh wow, sorry, I just had a stroke there in an installment. It will lead into a bile being secreted into the GIT tract, and that bile will contain the organism, and then that will result in secondary infection of the gastrointestinal tract, which will result in persistent infection. And one thing that's important, because of that in our first infection, what happens is then there's creation of oxygen-free radicals. And normally the organisms that are innate to our GIT tracts, they produce hydrogen sulfide as a byproduct of their metabolism. In non-salmonella typhi, so in non-typhoidal salmonella, because of those few oxygen-free radicals, it breaks down the hydrogen sulfide into your thiosulfate, and that thiosulfate gets changed into your tetrathionate, which is what now the salmonella organism actually used to generate energy, and then it overcomes the commensals of the GIT tracts, and it colonizes the GIT tract. The clinical presentation of non-typhoidal salmonella is quite heterogeneous. It can range from gastroenteritis, bacteremia, vascular infections, localized infections, and with the asymptomatic chronic carrier state. Moving on to gastroenteritis, it's usually self-limited illness that begins after ingestions of the organism, usually 6 to 48 hours. But it can persist for up to 7 days. The symptoms that one usually presents with is nausea, vomiting, and diarrhea. The diarrhea usually is loose to watery initially, and it might not have blood. At times, it can be watery in large volumes, which can mimic cholera, or it can be small volume with tenesmus, and that can mimic dysentery. The acute GE is usually indistinguishable from other causes of bacterial gastroenteritis. And the symptoms usually resolve within 3 to 7 days if it's mainly the gastroenteritis, and the fever in 72 hours. After this, some individuals will continue to shed the organism up to 4 to 5 weeks in adults and 7 weeks in the pediatric population. In some individuals, they can have a persistent gastroenteritis secondary to non-typhoidal salmonella with relapsing diarrhea for up to 8 years. And while we're actually talking about gastroenteritis, one always needs to remember that whenever you see a patient with an acute diarrheal illness, first, of course, you need to define if it's acute, persistent, or chronic on the basis of the duration. If it's less than 14 days, it's acute. If it's more than 14 days but less than 30, it's persistent. If it's more than 30, it's chronic. The causes are usually pathogenesis, usually secretory diarrhea. Mostly it's infective. It could be viral, it could be bacterial. And the commonly bacteria involved is your Campylobacter, Salmonella, Shigella, E. coli, and Vibrio cholera. Parasites usually causes a chronic diarrhea, and this is where the importance of traveler's diarrhea is important. Non-typhoidal Salmonella can present as a localized infection, which could either be a primary localized infection or it can occur as a complication of bacteremia. You can pick any system and you can have Salmonella affecting that system. In the cardiovascular system, you can have an endocarditis, and usually the patients that are at risk for this is patients with pre-existing valvular heart disease. You can have an arteritis, as rare as it is, but some patients can present with this, and particularly those patients with grafts, like our renal patients who have PMCADs and your brachiocephalic grafts for dialysis. And as a result of this arteritis, it can complicate with myocardic aneurysm, like our patient, Miss JM. It can have, it can rupture, it can form a fistula, and subsequently it can lead to chronic osteomyelitis due to seeding of the organisms into the bone. You can have the GIT tracts that gets involved. You can have hepatomegaly, a cholecystitis, or we can have a hepatic abscess that involves, as well as splenomegaly. So this is why non-typhoidal salmonella needs to be a differential for your patients that presents with splenomegaly. You can have the musculoskeletal that gets affected. In the bones, you can have chronic osteomyelitis, and in particular, patients that are at risk for this is our sickle cell anemia patients are at risk for this. You can have your joints being affected as part of a reactive arthritis or a septic arthritis. With reactive arthritis, usually it's more than 3 joints that are involved, and it involves the knee, the ankle, as well as the sacroiliac joints. The CNS can be involved. It can present as a meningitis, a ventriculitis, a brain abscess, or subdural impyemas, or it can present as encephalopathy, and this is more in your infants. The genitourinary tract can be involved with pyelonephritis and cystitis, and rarely the pulmonary system can be involved as well with a pneumonia that can lead to a lung abscess as well as an empyema. Patients with non-typhoidal gastroenteritis, up to 8% of them can develop bacteremia. The risk factors for this is certain serotypes of patients are at risk of developing this, especially patients with non-typhoidal Salmonella enterica enteriditis, the infants or patients of the elderly population, or patients with underlying comorbid conditions, especially if they are immune compromised because of impaired cellular mediated immunity. These are your retroviral positive patients, patients on immune suppressive agents, patients with underlying hematological malignancy, and our transplant patients. The infection can be either primary or secondary. Primary meaning that you just have an isolated bacteremia with no focal infection or no associated gastroenteritis, or secondary where you have a local infection that leads to bacteremia, or you have gastroenteritis, which leads to a secondary infection. And in sub-Saharan Africa, it's quite important because we have such a huge population of people living with HIV and patients also with malaria, sickle cell disease, as well as malnutrition, especially in the pediatric population. Your vascular infections, there are risk factors for it, especially patients with pre-existing valvular heart disease or patients who are more than the age of 50 with an atherosclerosis. And this should be suspected in patients who would present with high-grade fever or presents with persistent bacteremia. Invasive non-typhoidal salmonella is important in patients who are infected with HIV, because in some of these patients, it can lead to chronic GEs or persistent GEs. And if they've got recurrent salmonella infection, it actually is a classifiable WHO stage 4 disease. Paul Lishan, they describe a simple scoring system that was used to identify patients who are at risk of having vascular infections. in the setting of non-typhoidal bacteremia. In this scoring system, one thing that was more prominent is that patients of above the age of 50 with significant atherosclerotic disease had a high risk of developing vascular infections. As a result of the vascular infection, one of the complications is mycotic aneurysm. Mycotic aneurysm refers to the dilatation of an arterial wall due to infection, which was first initially described by Wislam Osler. Yay, Osler notes. The etiology can be bacterial, fungal, or viral. The pathogenesis could be from bacteremia or from local injury, especially as after intravenous cannulation, which leads to inoculation of the organism. It can be from a local spread or from a septic emboli. The common organisms identified is your Staph aureus, Salmonella species, and the histology, usually you will note a transmural inflammation with variable degrees of abscesses, necrosis, and thrombosis. Back to Mrs. J.M. She was taken to theater and she had ligation of a common femoral artery with the excision of the pseudoaneurysm. And unfortunately, they found that she had significant necrotizing fasciitis, and they had to debride and up to the bone, and you can see on your right-hand side. Some patients can have a persistent infection of the salmonella, and this is defined as a chronic carrier state, which is defined as a demonstration of the salmonella organism in the stool or urine for more than 12 months after the acute infections. And it occurs in 0.2 to 0.6% of individuals that experiences Salmonella gastroenteritis. It will be a sin for me to talk about a chronic carrier state and not talk about Typhoid Mary. Typhoid Mary, let me respect her at least. Mary Mellon was, she was an Irish-born cook in 1884, who actually infected a number of people, as she was an asymptomatic carrier. She was forced into quarantine twice in her lifetime. Then unfortunately, she succumbed to illness and she died alone. And since then, the name Typhoid Mary has been synonymous with the spread of disease or misfortune in people who are actually asymptomatic carriers. And the risk factors for chronic carrier state usually is associated with the use of antibiotic therapy. And typhoidal is most likely to be in a chronic carrier state. This is because it has an enhanced ability to evade the immune system. Diagnosis of non-typhoidal salmonella, it's based on demonstrating the organism on clinically relevant samples. So it could be from blood cultures, stool, urine, bowel, cerebral spinal fluid, and bone marrow. And bone marrow can actually become positive in a setting of a negative blood culture because the organism there is concentrated 10 times more than in the peripheral blood. There are some PCR-based tests that have been identified to demonstrate typhoidal and non-typhoidal salmonella, but these ones have only been shown to be of use in identification in stool sample, which of course does not mean that your patient is actually symptomatic with the disease, but then of course you analyze the results on the basis of your clinical presentation. So this is one of the articles that demonstrated the use of a real-time PCR to demonstrate typhoidal and non-typhoidal in stool sample. Non-typhoidal salmonella, as I've said earlier on, that the clinical presentation is varied and it can range from gastroenteritis, because usually gastroenteritis is uncomplicated and self-limiting. The treatment is symptomatic treatment, which is directed at replenishing fluids and replenishing of electrolytes. Antibiotic therapy, it's not encouraged unless there's certain indications, like in neonates below the ages of 3 months, the elderly, especially if they're older than the age of 50, as they are more at risk of having invasive disease, immune suppressed individuals, patients with underlying valvular disease, or those with endovascular abnormalities, those with significant joint disease or significant bone disease, like in your patients with sickle cell disease. The treatment of choice usually is your fluoroquinolones, your Bactrim, ampicillin. Also recently, azithromycin can also be used. But there's one thing that's important is that different regions, they've got different resistant strains. And commonly in Africa, there have been a lot of strains that have demonstrated that there were resistance from your fluoroquinolones. So that might not be our first line of choice in South Africa, but in other countries that can be. Your non-typhoidal bacteremia or disseminated disease does require therapy, and usually the initial therapy is a third-generation cephalosporin, such as ceftriaxone, for 7 to 10 days. Your focal infections or complicated disease requires a prolonged course of cephalosporins, usually for 4 to 6 weeks. Chronic care states, unfortunately, at this point, it's quite controversial if they require to be treated or not. In one study in Thailand, they did a study where they did a placebo versus the use of Bactrim or nalidixic acid. And it did show that there was actually no benefit in that study, and certain patients actually had more adverse outcome. So treatment is quite controversial, but occasionally in certain individuals, you can consider eradicating those individuals using your fluoroquinolones like ciprofloxacin. Individuals who usually come into contact with a lot of people, like individuals who are cook, like Typhoid Mary, who knows, maybe this could have been a saving grace and she wouldn't have died alone, or individuals like us, healthcare workers, who actually come into contact with patients on a frequent basis. And this is an article that actually talks about the emergence of resistant strains in non-typhoidal Salmonella, where they demonstrated that in patients with non-typhoidal Salmonella, even with no prior antibiotic exposure, most of these patients, they were resistant to ciprofloxacin. And one of the risk factors for this is that because of how our meat products are being procured, is that most of those chickens and cows, they are actually given antibiotics to try and clear out Salmonella in their GI tracts to try and decrease the risk of transmission. But unfortunately, that leads to transmission of resistant strains. Back to Mrs. JM, she was treated with ceftriaxone for 6 weeks after negative blood cultures. Unfortunately, subsequently, she had suspected fungal sepsis, which she was treated for it. And she was stepped down, currently receiving wound care and physiotherapy at Baseline Hospital. On your left-hand side, you can see how the wound looked like immediately post-op. And now this is how the wound looked like after 6 weeks of antibiotics, vac dressing, and debridement. Prevention of non-typhoidal Salmonella, it's our principles that we've been taught in high school: clean, separate, cook, and chill. Normally, one thing that's important is good sanitation, good hygiene, and excellent food handling skills are important in prevention of non-typhoidal Salmonella. And of important is that us as healthcare workers, we need to be able to identify the organisms or have a high index of suspicion for non-typhoidal Salmonella or even typhoid, so that we can identify the organism. And once identified, we can actually report or notify, and those individuals, they can be isolated and treated appropriately. And also the use of antibiotics when indicated in order to prevent the transmission of resistant strains, and vaccination. But vaccination has only been approved for typhoidal Salmonella, and there are currently only 2 vaccines that have been approved. It's an oral-based vaccine and an injectable vaccine. Some take-home messages is that Salmonella is a common cause of diarrheal illnesses, and the clinical syndrome is quite heterogeneous, and presentations can mimic other diseases, and one needs to have a high index of suspicion. Non-invasive diseases can be treated conservatively, and invasive disease requires antibiotic therapy for a prolonged period of time, and prevention is an important aspect of managing Salmonella infections. There's some references, and I would like to thank Dr. Sarah Stacey, Dr. Lyle Murray, as well as Ms. JM for my presentation. And always remember, when you eat your ice cream tomorrow, don't lick the bowl. Any questions and comments?
Thank you very much.